by Dr. Suraj Narasimhan. He's a consultant interventional cardiologist and structural heart specialist at Narayana Health City, Bangalore. He has an extensive expertise in complex coronary and advanced surgical interventions, including TAVI, mitral clip, transcatheter mitral therapies, and endovascular procedures. He's trained at some of India's and Europe's finest cardiac centers, performed over 500 TAVI procedures as the primary operator, and thousands of complex PCIs and a wide spectrum of congenital, structural, and endovascular interventions. He's an active international faculty, proctor for multiple structural platforms, and frequent presenter at major global meetings, including London Valves and Euro PCR. So we're delighted to have you here with us, sharing your insights and experience. Thank you so much, Dr. Suraj.
Thanks for the nice introduction. And I'll try to share some of the experiences which we have with the MCS devices, which we are routinely using in India right now. So our discussion will be regarding who requires the mechanical circulatory support and how does it help on what are the options which we have in India at present. What are the hemodynamic profiles of each and every devices? And I just want to touch upon the concept of LV unloading and also Impella step-by-step implantation and some case examples which we have had. So MCS is required in 3 clinical scenarios at present. One is as a cardiologist when we do high-risk PCIs, acute MI with cardiogenic shock, and acute heart failure due to other causes. So these are the most commonly used MCS devices available. Impella is there, VA, ECMO, tandem heart, and IABP. And IABP is the most easily available thing in our center as well, in most of the centers. And we know that the cardiac output augmentation with an IABP is going to be less than 10%, probably around 0.5 to 0.1 liter augmentation, which we can get. We can insert it through the femoral artery, axillary artery, but it is a counter pulsation mechanism. So it relies on the underlying native heart to be performing to a certain extent. If the underlying heart is very bad and there is no pulsatility, then IABP is not going to be helpful. And also it is very much rhythm dependent. So if your patient is having a lot of atrial fibrillation, fast ventricular rate, then probably the IABP doesn't work very well. And it maximum gives around mild hemodynamic support, and so it can be used in patients with mild hemodynamic deterioration. So it produces diastolic augmentation, wherein it increases the coronary blood flow and thereby it increases the cardiac power output. When it deflates in the systole, what happens is that it reduces the LV afterload, thereby it reduces the myocardial oxygen demand, so it is helpful for the heart. So it is going to be helpful for the heart because it is going to reduce the afterload, increase the coronary perfusion. Since it is going to increase the mean aortic pressure, systemic perfusion and organs are also perfused, but then not to a great extent. So this is what? Good for the heart and slightly okay for the systemic circulation. But there is another system called as a tandem heart, which we don't use routinely. So where we put a cannula in the LA and then decompress the LA, suck out the blood, and then we put it out through the descending thoracic aorta. So it produces direct LA unloading. It doesn't increase the LV afterload like that of an ECMO, but then this is also a non-physiological arterial flow. So you're pumping blood from the lower limb artery, which is against the aortic flow. It requires a atrial septostomy and it is contraindicated if the patient has a LA thrombus. It can provide up to around 4 liters of cardiac output. And there is another system which we have access in India that is called as a pulse cap that gives around 2 liters of output. It can be used in high-risk PCIs as a support, but then not for acute heart failure because the output which we get is limited to 2 liters. And it can be implanted percutaneously as well. And the major advantage of this pulse cat system is that it works on an IABP console. So it is widely available in most of the hospitals as well. And what about peripheral VA ECMO? So this is also another system wherein we suck out blood from the right atrium and then pump it up in the abdominal aorta. So it can give us a cardiac output of 1 to 7 liters. and it provides good organ perfusion. So that is the major thing about ECMO. It provides good organ perfusion. It works in biventricular failure as well. If the RV is dysfunctional also, ECMO works very well. And the major difference from all the other system is that this is the only system which can provide oxygenation. So if the lungs are bad, if the oxygenation is very bad, then the ECMO system helps in these kind of patients. But the major problem with an ECMO system is that it increases the LV afterload, and this also provides a non-physiological arterial flow wherein the blood is pumped from the descending aorta into the ascending aorta. So ECMO, by increasing the flow and increasing the aortic pressures, it is very helpful for the systemic organ. But then when it comes to the heart, it is not that effective because since we are putting up a non-physiological flow, the heart has to pump against the increased afterload. And it increases the LV end diastolic volume and it increases the LV end diastolic pressure. So it increases the microvascular resistance and it is bad for the heart. So this is what I was talking about. The blood is getting ejected from the abdominal aorta. The heart has to pump against it in the other way. And whenever there is a failing heart, there is a increased LV afterload. And when the ventricle is not able to eject because the afterload is so high, the aortic valve closes early and then it leads on to ballooning of the ventricle, increases the LV-EDP, and then it increases the myocardial wall stress and the demand, and the work increases. And even though it increases the coronary blood flow, it only has a neutral effect on perfusion because the demand also increases at the same time. Whenever the ECMO flows increases, so one thing which we have to notice here is that this is the pressure volume loop. Whenever the ECMO flow increases, the end diastolic pressure also starts increasing and we are shifting the curve towards the right. Whenever the curve gets shifted, that means to say that the end diastolic pressures are increased and thereby the myocardial oxygen demands become bigger and the ischemia progresses. And it also adversely affects the lung wherein it loads the lung and then it causes pulmonary edema, and it also causes worsening of oxygenation and north-south syndrome. It leads on to late recovery of the ventricle because we are putting a lot of stress into that. So whenever we put a patient on ECMO, we are actually shifting the curve towards the right, which is actually bad for the heart. So ECMO is very good for all the other organs and perfusion. The only organ which is not perfused properly is actually the heart. So we use multiple modalities to vent the LV, like direct LV venting, LA venting, LAVA ECMO, or we can add a Impella to that of the ECMO, that is the Impella, and we can do an atrial septostomy. These are the ways wherein which we can unload the ventricle. But then other than Impella and then the LAVA ECMO, most of the other surgical options are going to be very high risk in a patient who was having acute MI, who had a stent on multiple antiplatelet agents as well. So this is where the Impella system comes into play. Even though there are multiple Impellas like Impella 5.5 and CP and RV Impellas which are there, in India we have access only to the Impella CP, and that is the one which we routinely use for our patients. And this can give up to a cardiac output of almost around 3.5 to 4 liters, and it can be inserted percutaneously, and it is a 14 French system. And there is an inlet and an outlet. The inlet sucks the blood from the ventricle and then outlet pushes it out into the aorta. So the outlet, when the blood is pushed into the aorta, it is a physiological forward flow that we have to keep it into consideration. The flow increases, the aortic pressure increases, and the coronaries also gets perfused very well. The cardiac power output increases. When we suck the blood from the ventricle, we are actually reducing the end diastolic volume and also the end diastolic pressures. The wall tension reduces, the microvascular resistance improves, and thereby the coronary blood flow also increases. Ultimately, it reduces the demand and supplies more to the heart, whereby the inflow portion actually protects the heart by directly unloading the ventricle. Whenever the cardiac power output and the pressure increases, it is good for the systemic organs as well. So this is one system where it is good for the heart as well as for the systemic organs. I just don't want to go in too much of detail. There are multiple pressure settings which are available, which can be controlled through this automated Impella controller interface, which is kept outside, where we get to know all the values, power outputs, and the cardiac output and everything. And this is how we place the Impella into the ventricle. Make sure in the fluoroscopy, we usually do it in our cath lab. And then we put the position, the marker exactly at the level of the annulus. This is the inflow portion. This is the outflow portion. And this is the pump which works. The one good thing is that this pump is never in contact with the blood, because the blood is getting sucked from here and then it comes out of here, and the purge fluid is there continuously to make sure that the blood doesn't enter the motor system and make it stop. What are all the checklists which you have to do prior to implantation of an Impella? Make sure that there are no contraindications like a VSD, an LV thrombus, or any prosthetic mechanical aortic valve or severe aortic regurgitation. Make sure that the patient has good access femoral arteries, and the RV function has to be good. If the RV has failed, then the Impella doesn't work. And if the lung is completely affected, since Impella is not going to give you any oxygenation, this is not going to be as effective like an ECMO, which is going to actively provide you oxygenation. So this is the insertion kit which is there. Access the femoral artery, ultrasound guided, put the pigtail into the ventricle, load it over a 018 wire, keep it in the appropriate position, and that is how we usually do. Ultrasound guided puncture is essential. Make sure that you take it in this common femoral artery, and then you put in the 14 French peel away sheath, and then you can go into the ventricle with the 018 wire or the regular Teflon wire. Once you are inside the ventricle, you can exchange it for a 018 wire, and then you can just slide the Impella, even if it goes through very well in tortuous arteries and as well as tortuous iliacs. You position into the ventricle, and then you connect the motor and you start your Impella system. Make sure that the markers are kept in the proper place. Echo and fluoroscopy guides in positioning the Impella like this. And once you are in this position, your Impella recordings and the tracings you can just see. And if everything is fine, then you can flow on the system. And if it also helps us guide in whether if you are too deep into the ventricle, then both the signals will be in the ventricular fashion. If you have the signals will be in the aorta, make sure that it is something like this. There is an aortic waveform as well as a left ventricular waveform, and it gives us the motor current as well. So this is the basic about this thing. But if you want to do an angioplasty, you don't have to take another access. So you can use a single access procedure like this. So where you can puncture the diaphragm at 10 o'clock or 2 o'clock position with a micro puncture set, and you can put in a 7 French sheath, and then you can do your angioplasty as well without any issues. The major advantage of an Impella is that ECMO shifts the pressure volume curve towards the right, but then if you see Impella, it actually shifts the pressure volume curve towards the left. Whenever it gets shifted towards the left, it is very, very helpful because your end diastolic pressures are going to be lesser, and your coronary perfusion and microvascular resistance are going to improve to a better extent. When we increase the Impella ECMO flow, the pressure volume curve shifted towards the right side. But then when you increase the Impella flow, actually the suction is going to be more. So your pressure volume curve gets shifted towards the left side, which is very good for the coronary perfusion. So like I mentioned, an IABP can support to a heart to a certain extent, but Impella provides active unloading of the ventricle. ECMO produces more afterload, but then it unloads the RV as well. So these are the basic difference between different MCA systems which are available. So we'll just see some few examples where Impella is helpful in the coronary or angioplasty whenever we do, or an acute heart failure. So we will see. So we select patients according to this criteria. Yeah, patient who has multiple comorbidities In a complex anatomy and a multivessel PCI, like a CTO, calcified lesion, unprotected left main, in a patient who has hemodynamic compromise, when the LV dysfunction is there, and also patients who are hemodynamically unstable and patients who are all decompensated. You select these patients, and that comes as the CHIP patients who are suitable for an MCS support. The more the complexity, the more the CHIP score increases. And then there is a guidelines which says that if you have a CHIP score of more than 4+, then probably an MCS will be the adequate thing which is required. How does an MCS help? MCS helps in CHIP PCI to reduce the oxygen demand during the procedure and increase the oxygen supply, like we discussed before. Ultimately, during the table, when you are doing the angioplasty, MCS provides us very stable patients. It prevents intra-procedural cardiac arrest. It arrests the ischemic cascade from spiraling down, and it gives us more time to intervene. Whenever we have more time to intervene, we revascularize more vessels, and also during the procedure, it prevents ischemia-related arrhythmias. Everything ultimately leads on to complete revascularization. So this is a patient who had a critical ostial LAD distal left main disease, the SIRC disease, and then this patient had a calcified lesion which required a rotablation. You can see what happens during rotablation. Before rotablation, there is a pulsatile flow which is there. But then during the rotablation, you can see that the pulsatile flow is not there, and it is a continuous flow which we can say. So here the heart is working fairly good, but during the rotablation, just because this patient had an Impella, this patient pressures did not dive down and had a cardiac arrest, and this continuous flow suggests that the MCS is working at that time to maintain the mean arterial pressure without much of pulsatility. Once the rotablation is done, you can see that the pulsatility comes back again. If this patient has underwent a procedure without an Impella, what would have happened is at this place, the patient would have crashed and you would have had an intra-procedural cardiac arrest, and that would have led on to a terminal event. At the end of the procedure, once the complete revascularization is done, you can see that the LV has improved nicely, and this patient's Impella was removed at the end of the procedure, and this is how this patient went home without a terminal event. So the PROTECT trial also shows that your intra-procedural hypotension reduces by around 78% if you have a mechanical circulatory support with an Impella. And this curve says that initial phase as well as during the late follow of 90 days also, the curves keeps diverging. This is because all the Impella supported patients had a complete revascularization when compared to the IABP supported patients where they did not achieve complete revascularization. Even though at the initial point, at the time of discharge, both the curves are same, but then it keeps diverging because these patients with Impella received a complete revascularization when compared to the IABP cohort. So the complete revascularization is the mantra where MCS helps us out, wherein Impella plays an important role. And like the previous speaker, it is always an Impella which is preemptive, implanted before the procedure, which has better outcomes rather than bailout Impellas. Bailout Impella is nothing but you have the Impella system in place, you don't implant it, do the PCI. If there is a cardiac arrest, then you implant the Impella. This doesn't work out well. The MCS major goal is to prevent the cardiac arrest and hemodynamic deterioration. So it is better that you implant the Impella from the beginning rather than keeping it as a backup or as a bailout. It works well in surgery as well as in cardiology because events are going to be much lesser. Bailout mortality is around 57%. Upfront Impella mortality is around 4.4. These are all same matched cohorts. So that means to say that if you decide on an MCS, you go upfront rather than wait for the complications to occur. Ultimately, we get more time in these patients. So we do more rotablation, we do more angioplasties, we revascularize more vessels, and then the event rates are going to be much, much lesser. And that is how an MCS helps us in high-risk PCIs. So what about the indication? So indication in the newer guidelines says that it has been changing from a lot, and we have come to a stage wherein if you have a high risk PCI in a high risk center, then probably it gets us a indication of around 2B. That is what the current guideline says. But then usually probably in the future, when more trials comes with the high risk PCIs, then probably this indication will be class 1 in the future. So the other spectrum is acute MI and cardiogenic shock. So you revascularize a patient after you make sure that your vessels are flowing well, but then the heart doesn't improve immediately after revascularization. What happens is that there is a time where there is a stunning is there. So you have revascularized, but then the heart is not functioning. And this is the time where the stunning is there, where the LV has to improve. This is where an MCS comes into picture. If you directly unload the ventricle when the patient is in stunning, your LV-EDP is going to be low, your wall stress is going to be low, and their oxygen demand is going to be low. And this is ultimately going to give more rest for the heart. Your LA stretch reduces, the incidence of ventricular arrhythmia reduces, and the incidence of atrial fibrillation also reduces. And that is how in acute MI stage, if you actively unload the ventricle, that is the best form of protection which you can give to the heart. And ultimately, after 2 or 3 days, probably max up to 1 week, most of the LV recovers, and then we will be able to take out the Impella from these kind of situation. IABP is good for the heart, but then it is not going to support you. ECMO is good for the systemic organs, but then not good for the heart. ECMO is going to be good for the heart as well as for the systemic organs, and this is the best form of MCS which you can give for your patients if suitable enough for unloading the ventricle as well. I just don't want to go into too much of details. What about the guidelines? In 2013 guidelines, IABP had an indication of 2A in cardiogenic shock, but then right now in 2025, ACS cardiogenic shock, it is class 3 and it is not recommended. Impella, previously it was 2B. Right now in the current guidelines, it has received a indication of 2A after the danger shock trial. This is a patient, 56-year-old male, diabetic, hypertensive, anterior wall MI, profound shock, 3 inotropes, an attempted PCI done elsewhere failed, an ejection fraction of 20 to 25%, and he had a cardiac arrest, and then they were able to resuscitate, and then they have sent this patient to our hospital. That time he was doing okay mentally with multiple inotropes. So we put this patient on an Impella, and then we started the procedure. So we didn't start the angioplasty first. We put the Impella, then only we start the angioplasty. Impella is implanted in the routine way which we usually do, and then we punctured the hole and then we put in the Impella. So these are the readings which we have got. So a pulse pressure which is less than 330 millimeters, and then you see the hypotension which is there, and this we have started it at P7 at this time, and then we did the RCA angiography. It was fairly good, and the LAD was totally occluded. The POBA which was done for the diagonal was also occluded from the outside hospital. We were able to rewire the ventricle LAD, and then we did the angioplasty, and then we put in a stent, and this is the flow which we were able to achieve. You can see that the septals are flowing very well, and we post-dilated the stent, and this is the final results we were able to achieve for this patient. And slowly after the revascularization, we saw that the blood pressure slightly improved to a certain extent. The pulse pressure was slightly better, and we can see that there is a good flow in the distal vessels. So we didn't put any distal perfusion cannula for this patient. Slowly we can see that the LV is recovering, and right now we have a pulse pressure of almost around 40 millimeters, and then our cardiac power output has increased to 1.0, and we had a good cardiac output of 5.4. And then we did the trial of reducing the P flows. We can see that the curves are diverging nicely. The Impella flow is reduced, and you can see that the mean arterial pressure is maintained, and your cardiac output has also increased nicely. So this patient was taken out of ventilator, Impella was removed. There was an AKA in sepsis which was treated, discharged on the 12th day. This patient is under regular follow-up and is doing well. And this was closed with a MANTA, that is the usual closure device which we use for our Impella patients. What about other kinds of heart failures, acute heart failures? What can happen is we know that A, B, C, D, E is there. E is the extremes, but then that is not the time to catch these patients for a MCA support. It usually starts when the lactate starts elevating and the inotropic starts getting increased. And this is a stage C is the ultimate time and the effective time to put these patients on peripheral VATs like an Impella. The more the patient worsens, if the shock is left for a longer period without treating, these patients don't do very well, even if you put those patients. So timing is very, very important. Early detection and then early support for the LV is going to give you better outcomes. 74-year-old male came with non-ST elevation MI. He had an ejection fraction of around 40%. The patient was fairly stable without any inotropes. And this was the echocardiographic pictures. Hereditary hypokinesia with the EF of 40%. MR is only mild. And we take him up for an angiography. We can notice that there is a critical disease in the ostial LAD and it is also heavily calcified. Circ is okay, but then this OM had a tight lesion, which is over here. And RCA was totally occluded and it had collaterals from the left system. So this was a chronic occlusion. This was the reason for his acute coronary syndrome, that osteoproximal tight LAD. And we revascularized the circumflex and we did an optical coherence tomography, which showed that there is significant amount of calcium. We had done an angioplasty for the circumflex, and then now we have to concentrate on the LAD. And LAD was also a heavily calcified vessel. We can see that this orange things which we are seeing shows that there is significant amount of calcium. Calcium modification in this case was done with an orbital atherectomy. So that is what we are doing over here. But after the orbital atherectomy, during the procedure itself, the patient had some mild slow flow. And we were able to put one stent in the mid LAD, and then we were ready to take another stent. And when we placed this stent in the ostial LAD, then this patient had a cardiac arrest and a ventricular fibrillation. We just gave some massage. At that time, immediately, we didn't have Impella in our cath lab because this patient was a fairly stable patient with not much critical diseases, the ejection fraction of 40%. He did not qualify for an MCS upfront to begin with. So we were able to put in an IABP, we were able to revascularize the vessels. We put 2 more stents into the left main as well as into the circumflex, and we achieved a good decent flow. The RCA also started flowing well. But then when we did the echocardiography for this patient, the LV function from 40% has come down to almost around 15%. This is because of the stunning as well as the slow flow which occurred during the procedure. That is the reason why the LV went in for a toss at that time. So we shifted the patient with IABP and minimal inotropic support. But then when we noticed over the next 8 hours, the pH started decreasing and the lactate started increasing. So we consulted our heart team, and ECMO was an option as well as an Impella was an option. As we all know, ECMO is not very good for the heart, especially in failing hearts, ACS patients. We put this patient on an Impella, and we always put a PA catheter also in these kind of patients to monitor the cardiac output. His pressures were low, very low to begin with. PA pressures were also on the higher side. But then the moment we put the Impella, you can see that the graph is coming down. The lactate stabilized over the next 2 days, and his LV function started to improve fairly. And after 3 days, his EF became around 40%. And then we were able to take out the Impella successfully. And then this patient was discharged home after around a week or so. This patient also had a kidney injury, and this patient improved over time. And this is his echocardiography after 2 months follow-up. And we can see that the LV function is almost back to normal. LV, LAD territory is contracting very well, and there was no issues. So this Impella helped us to save this patient in a post-procedure slow flow acute myocardial stunning because of that. So this is another interesting case. 85-year-old lady with flail mitral valve, AML cord rupture, severe mitral regurgitation, and her coronaries were normal, BNP was elevated, multiple heart failure admissions. This was her echocardiographic findings. You can see that there is a significant amount of prolapse and also significant amount of regurgitation. You can see that the left ventricular function is to begin with is actually not very bad and it is fairly okay. We did a GLS study for this patient. The GLS was coming around 17. So that says that there is some amount of underlying myocardial dysfunction which is masked by the regurgitation. Whenever there is a regurgitation, we cannot assess the LV functions completely, and that is what was for this patient. And then this patient underwent a transesophageal echo, which showed that there is a significant mitral regurgitation. I'm sorry for the slide, there is some issue with how it is working. And we were able to see that the prolapse and the rupture was in the A2P2 segment, and we were able to take a mitra clip in the proper position. We were able to go step by step, and then we were able to put in a clip in the exact position, and we were able to achieve an excellent result after the single clip. And we wanted to stabilize the system with another clip extra. So this is the mitra clip. First clip was implanted in this position. You can see that the prolapse has grossly been reduced after that, and the flail tissues are also been plastered very well. We released the first clip. The gradients were not that high. Usually when we do for these kind of flail leaflets, we always put in a second clip close to it to stabilize the whole system. That is what we did for the patient, and ultimately we ended up with very, very minimal mitral regurgitation. So the LA pressures came down nicely, and V wave also came down. The MR was less than mild MR, and the gradients was around 5 millimeters at the end of the procedure. But then when we did the echo, we found out that suddenly the LV function has grossly deteriorated from 60% to begin with almost around 10% on table. The patient became completely hypotensive and started requiring inotropes. So this is all because of acute afterload mismatch, which can happen in a patient with chronic mitral regurgitation. Whenever there is an MR, there is two outlets for the left ventricle to pump. One is against the aorta and afterload. The other one is against the low pressure system into the left atrium. But when you clip these patients, what happens is that the easier outlet, that is the LA outlet, is not, it's completely closed. So the whole ventricle has to pump against the afterload of the aorta. And that is where these patients become bad, and then suddenly LV deterioration happens and the cardiac output reduces. And even though we have treated this patient with the regurgitation, they end up with a low cardiac output failure, which is very common in patients who have been having long-standing mitral regurgitation. So we put the patient initially on IABP, and then the patient did not improve. So we wanted unloading of the ventricle. So we put this patient on an Impella, and then we were able to successfully wean out this patient after 3 days. And this patient's LV function from 15% improved to the pre-existing 50%. So that is how an Impella helped in this patient. And you can now see that the ventricular functions are much better. The clip is functioning well, and there is hardly any regurgitation. So in this patient also, in acute heart failure, his LV function improved and the patient was stable enough just because of Impella. ECMO would not have been helpful in this situation because you are going to increase the afterload and you are not going to rest the ventricle in a peripheral ECMO. So that is
Dr.
how
Suraj,
this patient.
sorry to interrupt, sir. Could we just wrap up in the next couple of minutes so that we have some time for questions also?
Almost done. So I just wanted to show this. So we can combine things together as well. You can put an Impella as well as an ECMO, which is very good. You can put an ECMO and IABP also. That is also good because it reduces the afterload. And when you have an Impella and IABP, both of things doesn't work. So either Impella or IABP. Once the patient gets an Impella, then you remove the IABP. So the take-home messages are CHIP PCIs, Impella is helpful because it provides stable hemodynamics ultimately complete revascularization. Acute MI, it is very helpful because it is going to unload the ventricle and increase your perfusion. Acute heart failure, it is very, very helpful because it is going to unload the ventricle and then it provides a systemic perfusion. Impella provides the best balance between unloading as well as a robust forward flow during the CHIP PCA as well as in acute heart failure. IABP doesn't improve the outcomes as well and it produces limited support. VA ECMO is very, very helpful when oxygenation is required, but then it increases the afterload. Whenever you put these patients on VA ECMO, you have to think about venting the ventricle by some other mechanisms. Thank you.
Excellent talk, Dr. Suraj. Thank you so much. Excellent talk by Dr. Shehada as well. I think we'll open up the forum to questions by the audience. And any comments or questions from Dr. Manoj sir, Dr. Jabir sir, Dr. Joe sir, Dr. Julius had asked something in the chat. Maybe it'll be better if we discuss in this forum now.
Dr. Shehada, I've just got a question for you. How do you prepare your patients, like even Dr. Suraj? Say, for example, we have these poor LVs whom we stabilize with GDMT for a month or so prior to surgery. Do you have that kind of protocol, or you just you quicken and get your patients right on the table?
Yes. Thank you very much, Sarah. It's a tremendous question, actually. As I told you, earlier, we have been reactive for patient presenting with a severely impaired left ventricular function. We go to the OR as a surgeon and we say, like, I'm gonna do this and that. And if it's not working, we're gonna do an ECMO or ECLAS or whatever the configuration is, subclavian, right groin or something like that. It was like for years my primary experience with these patients. I go to the patient with an ejection fraction of 20%. I say, like, okay, I'm gonna do 5 bypasses. I'm gonna repair the mitral valve, and it's not working. I'm gonna put an ECMO. But today, if you don't have an emergency setup, you have like an elective setup. We also need to prepare this patient, as you already mentioned. So we put an echocardiography, exactly interdisciplinary, discuss what we are going to address. Are we going to address everything, or we're gonna split it up between us? I mean, like, for instance, we can do like an off pump mid-cab plus stenting for patients with a failed left ventricle. Does not need a complete revascularization immediately or something like that. This is one of the points. You can do also calcium sensitizers for these patients before you put them in the OR. We had like a great success with that in patients having coronary artery diseases. You know that the Stitch trial have shown that even the patients having a problem, and even they have long-term coronary artery disease, that even have been advantages of coronary artery bypass revascularization. So these patients, I put in the not ICU, but the intermediate care. We do an echocardiography before procedure, and we can start up with calcium sensitizers, and then prepare the patient not only mentally, but also sometimes we do the screening for the long-term assist devices before we put him into the OR. So it's
your surgical colleagues can have more prepared patients, but then acute MI cardiogenic shock, there is no role for preparation.
Different.
Most of
It's a
the
different thing.
acute situations, we don't have time to prepare, but there are few instances where we make sure that the patient is adequately diuresed, especially in high-risk PCAs. So these patients receive a GDMT, and we do a CAT study in most of these patients prior to the procedures. We look at the PA pressure at the time of the procedure as well as the LVEDP. And if the LVEDP is going to be very high, then PA pressures are high. We take the patient out, diurese them properly, and then prepare for the procedures. And the third situation is the mitra clips, which we commonly do. And most of our functional MRs, we always pre-treat the patient properly, because one of the indication for mitra clip is make sure that your GDMT is there for 3 months and she is not responding to that. And when we admit those patients, 24 hours prior to the procedure, we start the patients on dobutamine or levosimendan to prepare these patients so that we don't end up in an afterload mismatch. And most of our primary MR patients usually have a good functioning ventricle, so we don't usually prepare them that much. But then we have burnt our fingers in that way. So we always use a GLS for all these primary MRs as well. And if we find that GLS is going to be low, then we usually pre-treat them with 24 hours of levosimendan prior to taking in for any procedure.
Doctor, I mean, to the cardiologists out there, you have LVEF of 60%, severe MR, post mitral replacement 20%. LVDP by DT is something which, I mean, we practice normally rather than looking at just 60% EF. I mean, is that a good standard for you all? I mean, other than GLS, where people don't have the GLS software.
There are multiple ways which we can do. So echocardiographically, we can look at the diastolic dysfunction. And if you have a cardiac MRI, you can see how much of fibrosis there. But then rather than a bad LV to begin with, it is actually an acute phenomenon which occurs. You suddenly stop a low pressure system where the ventricle can pump out to. So it is like stunning which happens in these left ventricles. And most of the times what happens is that your ventricle ultimately improves. That is the first 1 or 2 days where the ventricle is not able to tolerate that much of stress it is put into. So even though the ventricle is not very bad and then ultimately they improve, it is the acute stress which is there. I think most of the surgical colleagues also will understand. But the major advantage of the surgical colleagues is that they can take the patient out with a pump and then you can take it out later. But then when we do the procedure, we don't have any other supports. Suddenly, if the LV fails, we don't have bailout options. So this IABP and Impella are the things which can help us out in these kind of situations.
So
I
that's an
can
excellent
comment on
talk.
this as well.
Suraj, you have surgical colleagues at a short call.
But I am expressing my hindrances and the issues which face immediately during the procedure. Our surgeons are the best persons to help us out with, because we have a very good surgical team to help us out. But then during the procedure, at the time of the procedure, suddenly if something goes bad, then we want something to bail us out. So these are some mechanical supports which can do that.
You still have surgeons around. Okay, so I was just wondering, what is the incidence of conversion from Impella to LVAD? I mean, as in a durable LVAD.
Thank you very much. It's a very good question, actually. I answered it depends on many factors, actually. So in acute setting, the cardiogenic shock, Impella or even Impella, I mean, like some patients does not only have an Impella, they have an ECMO and we upgrade to an Impella or something like that. So these patients go immediately to screening. So we have about in cardiogenic shock settings, patients who are reanimated sometimes for 1 hour or something, have like 13 to 20% patients succeed to be eligible for LVAD. Some patients, even they are younger, they are not eligible for LVAD. They have different kind of pathologies, or they have like chronic diseases or whatever. So, or they even don't make it. So we already know that the patients with cardiogenic shock undergoing Impella therapy, most of them, they have like 40 to 50% mortality. This is in the first 24 hours. But even you stabilize them and everything, they have like a huge shock that's completely shocked the whole organs, and they have multi-organ failures. But if the patient succeed to pass and stabilize, we start to screen him immediately, and we have like results between 13% to 20% to be converted to long-term assist devices. This is according to our data so far.
When we look at the cardiogenic shock work group data, the improvement which we have seen over the last few years in terms of survival is not related to native heart survival. It is mostly from heart replacement survival. Do you agree with that?
Yes, of course. Of course.
Yeah.
This is an important thing. This is an important factor to consider. But also, I can comment on also your other comment regarding to hemolysis. Can I? Dr. Aditi, she commented that hemolysis is much less than in patients with a 5.0 or 5.5 compared to CB. Actually, surgical Impella, even we are working in a very interdisciplinary team. So sometimes I go to my colleagues in the cath lab, putting them in Impella CP through the right axillary or left axillary artery because the patient has like a severe pathological aorta or something that like that, so they can either do a high risk PCI or even do a mapping of the left ventricle or doing some rhythmological procedures. So I noticed that hemolysis, most of the cases where you put the Impella. The position of the Impella is very important. It's not only the size of the Impella. I mean, like if you can put an Impella 5.5, and if you put it like it was like slipped and go up there behind the mitral valve immediately, you will have an hemolysis within 10 minutes. You will see immediately the urine outputs becoming red. And if you put it so deep or so far away back, you will have like an aortic regurgitation and complications. So the hemodynamics, meticulous hemodynamics observation of the Impella is very, very important. So I think during Impella implantation and post-Impella implantation, it's very important to have an overview and you have a good team who knows exactly what's going on. So just go through, and Impella CB or Impella 5 or 5.5 all have, I think, in my eye, like hemolysis, as long as they are not putting well or not positioned well.
Most of the studies have shown that the hemolysis with the Impella CP is actually more than what you get with an Impella 5.5, because the lumen is actually only 14 French in that of the Impella CP. So the hemolysis is actually more. So 5.5 has a lumen of 22 French. So the hemolysis is actually lesser with the larger Impellas when compared to the smaller Impellas. The other one is the amount of flows which you are running. If you keep it at high flows, the hemolysis is going to be more. And if you think that you can reduce the flow and then make sure if the position is okay, and the amount of LV size also matters. If the LV is very underfilled and if the LV is having suctioning, so those are the times where hemolysis is going to be more. You load them with fluids, make sure that the ventricle is bigger and your position of the Impella is good. Your flows are kept in the optimum range to maintain the map rather than just to go higher and higher. And these are some of the things which can help us to reduce. But only misconception is that most people think that bigger Impellas has more hemolysis. Actually, the bigger Impellas have lesser hemolysis when compared to the smaller ones.
And what is your experience with biventricular support with Impella?
I don't personally have, sir might be having.
We had, in Germany, we had limitation to using Impella at the right side. I have been using it for very selected cases. So most of our patients, they having biventricular function failure. We use an Impella and ECMO. Most of our configuration are subclavian or auxiliary artery for the ECMO and Impella, and a so-called Impella 2.0. But this is a completely different talk. I will maybe share next time different configurations, how to do and where to do it. But if the patients have biventricular failure, we can use an ECMO plus Impella. We can use also a tandem heart plus Impella. I had a very selected cases using double Impellas, and we don't have a great successful rates with that.
I see. Yeah.
So far,
I was basically asking about double Impella because we don't have tandem heart with us. It's not available. And we still don't have 5.5, but it should be available soon.
That's great. That's great. I think the configurations of Impella like 2.0, and we have like a special configuration in SN I have been invented over the past couple of years, like doing a partial sternotomy for the patients with a very, very small aorta, especially like my youngest patient who is quite adult, having an Impella 5.5 was an 18 years old.
Yeah.
He made it through. So, and I had putting Impella in patients up to 80, 82. So it depends into every patient's presentation, what kind of presentation, what he's going to have, which procedures, doing with, is it a cardiogenic shock, is it a post-cardiotomy cardiogenic shock, is it severely impaired ventricular function, it's different. But we use Impella in different configurations. Like sometimes I do like Impella from one side and ECMO from other side, or vice versa. And sometimes you do it in a Y graft, like an Impella or point two. Sometimes you do peripheral ECMO, central Impella, or sometimes you do an ECMO and you have like a peripheral CP. It depends on to which patient. That's why I always say patients with cardiogenic shock, they have one thing, every minute is very important to monitor everything. So echocardiography on a daily basis is very important. Sometimes we do it like 3 times a day. I know that's in USA. I have the discussions last year in Dallas during the Impact meeting. They started to discuss about echoes and stuff because it's very expensive there to put there, because we buy an
those are
echo.
not problems for us. We can have it 20 times a day.
We
It's not a
have,
problem.
there's an echocardiography in our ICU, and everybody's eligible to do an echo.
Yeah.
Most of the time I push the device and I do a very fast echo when I need to know something. So it's very easy. You have an X-ray, you can see the position of the Impella. You have a Swangan's or pulmonary catheter, so you can monitor the hemodynamics. You have the new Medtronic device, which you can put it into the CVB, and you can have like a simulation of the right ventricular function. So it's not like a Swangan's, but similar. So you have like different new techniques which can support you to hemodynamic monitor these patients in a regular basis every couple of minutes. I mean, like you don't have to wait for long. My experience with waiting is always losing. So we monitor these patients very close. And actually, I have something to say, but I don't have like the last Impella I explanted yesterday afternoon, but I have something in the form called like Impella Connect, so I can watch all my Impellas that are implanted in the center we have,
Right. Yeah.
which one and everything, and how it's running, and every minute. And you can see it. Just wake up in the morning and you can see how it was going overnight. If everything was okay, there was a section or something, or a malpositioning or something like that. So you can call and immediately give a feedback to your fellow or resident to say like, you need to reposition or do something for the patients. You know that patients mobilization from the nurse team, sometimes you dislocate the Impella or sometimes you move it or something like that, so you have to monitor it, in a regular basis.
Suraj, you had put an Impella on somebody 90 plus, isn't it?
Yes, sir.
That was the mighty
That was
clip.
that clip patient which he had 89 something plus.
Right. Yeah.
Actually, Impella with a mitral valve is a very important issue. Actually, I always say the valvular diseases are very completely different from the coronary diseases. Most of the patients have coronary diseases that always profit from coronary bypass or revascularization in general. I mean, like if you do BCI and he has like more flow, this left ventricle or this ventricle is going to recover. But in patients with the valvular disease is completely different. I show in my slides 2 different patients. One patient has a mitral valve, ischemic mitral valve, plus coronary artery diseases, and the other patient has like severe mitral regurgitation and severe aortic regurgitation. The patient has a severe mitral regurgitation on top of chronic atrial fibrillation, like a functional MR, but it was worsening his left ventricle immediately. So, and he was 81 years old. So this patient was generally in a fit situation, but he is complaining over the past couple of months, having been readmitted with severe dyspnea and uncomfort. So you can't put this patient for an heart, like chronic heart support or something. So you have to try to remove the valvular pathology, and you have to put him in a chronic monitoring for heart failure. So we did a procedure with a mitral valve repair and aortic valve replacement, supported with the Impella, and he did great. I saw the pictures 1 year later, and he came like a couple of weeks ago for the second year follow-up, and he's doing great actually so far. So I don't say like this is going to be perfect for every patient, but I say like meticulous consideration for each patient and different patients and interdisciplinary discussions. I even discussed today protected cardiac surgery in our cardiology meetings. So they became familiar with that. And they discuss, okay, Impella CB versus Impella 5.5, surgical or not. So it's actually great discussions. And you gain more comfort to using the device. So less complications. I read one of the questions from Dr. Arno. Complications of Impella is a very, very important question. So I have a table showing all kind of complications we could consider. Hemolysis is the very first one. You can do a nerve injury during preparing the subclavian. You can do a thromboembolic complications. You have a embolicite infections. You have an embolicite bleedings. You have all kind of complications. So an immediate and continuous monitoring, meticulous monitoring of these patients is very important to diminish complications. However, these patients are not an elective cardiac surgery or elective patients. They are also coming in a severe heart failure or chronic heart failure or a cardiogenic shock. So they are not the normal cardiac patients that we always see in the street and say like, okay, he has like three vessel disease, he will be profiting from BCI or cabbage or whatever. No, these patients are unfortunately very long time sick and have like a heart failure for a long time, either acute or chronic or even cardiogenic shock. So they're completely different category of patients. And there's no device without complications. You can just consider that.
As for nerve injury, we found that if you do the deltopectoral groove, the nerve injury chances are higher compared to subclavicular approach to the axillary artery, because there is
I
no
think
brachial plexus at that point.
Thank you so much to
One
our
thing to
speakers.
avoid
In the interest
peripheral
of time,
complication. Sorry, one thing to avoid regarding peripheral complication, if you do a femoral Impella, is make sure that you do an ultrasound guided puncture. Make sure that you take it a proper puncture, micro puncture set, and you make sure that the site is proper before implanting the Impella. So this is one of the major complication which can happen if you are doing percutaneously. And at the end of the Impella high risk PCA, you take an injection and check whether the flow is there proper in the peripheral circulations. If at all, if your peripheral circulations are not proper, because these patients with cardiogenic shock, they have smaller femorals, multiple vasoconstrictors, their flows will be much, much lesser. In these kind of situations, you can do a arterial stick in the SFA and you can connect it to the side port of the Impella itself, like an ECMO, where you can just perfuse both the lower limb artery as well as the other thing takes care of the heart. So that is one thing which you have to make sure that the peripheral limb is perfused well and your puncture is good without any complications.
I think in the interest of time, we wrap up, though this has been a very engaging discussion. Thank you so much to our speakers for an excellent set of talks and very practical pointers. I'll just mention that our next webinar is going to be by Dr. Fernandez Castillo, who's a transplant pulmonologist trained at Toronto General, now practicing at University of Miami, on chronic lung allograft dysfunction. So we invite everyone to participate in that. And I'll ask my academic co-chair, Dr. Talha, to give the closing remarks.
Thank you, Dr. Aditi, and thank you once again to all the speakers and all the EC members and the remaining audience that has joined in. This was really engaging, and unfortunately, due to the time limits, we had to cut down the discussions. However, we would love to have Dr. Shehada and Dr. Suraj come back for more webinars, perhaps on different topics. And thank you again. We would end the webinar at this point. Thank you.
Thank you,
Thank you
Dr.
very much for
Shehada.
considering me. I hope you arrived safely, Dr. Talha.
Yeah,
Thanks.
Hope to see you soon.
See you.
Thank you
Bye.
very much.
Dr. Suraj. Bye.
Thank you. Thank you. Thank you,
Yes.
sir.
Thank you very much.
Thank you.
Thank you.
Hope
Thank
to
you,
meet you
Joe.
at ISHLT this year.
Sure. Take care. Bye.
Thank you very much.
और महाराष्ट्र चैप्टर के लिए किसने किसने रजिस्टर किया? मैंने किया ना।